screen, Dr. Chan? Okay, good afternoon, everyone, and good morning to people from the West. My topic is performing office hysteroscopy for the beginners. Now, I'm going to be very practical. I designed this lecture for private practitioners who want to do laparoscopic surgery in their clinic as an office procedure. I've been doing that for the last about 8 to 10 years, and I've got a lot of experience doing this procedure. So I'll outline how I go about performing office hysteroscopy in my clinic. So this is the outline of my lecture. So it's going to be a very practical lecture as to how I run this office hysteroscopy procedure. So the outline is that, first of all, I would like to give an outline of how I run my clinic. In Malaysia, the way in which we run our clinics may be different from other countries like Taiwan, Korea, Japan. So I just want you all to understand how our system is in Malaysia. Secondly, I would look at what are the instruments I use for office hysteroscopy. Then how do I prepare for the office hysteroscopy, how I perform the office hysteroscopy, and what I do post-operation, post-procedure, the types of procedures I do in my clinic, and the advantages and the disadvantages of performing this procedure, and then I will conclude. So this is the outline of my lecture. So the first is, how do I run my clinic? I want you all to understand how my clinic runs. Now, first of all, as I told you, I'm a private practitioner in a private hospital. I own a clinic in a private hospital. This is the private hospital that I work in. It is about 300-bed private hospital in Melaka. It's 25 years old. I run a clinic somewhere here in this building. And my clinic is about 915 square feet. It's about 85 square meters. Not a very big clinic, but for my center is one of the biggest. And this is how my clinic looks from outside. And I have a waiting room, a consultation room, a treatment room, a second consultation room, a nurses and audiovisual room, and a treatment room. And I just give you an idea of how the clinic looks. And this is how my waiting room looks. This is it's got a few places for patients to sit, and this is the waiting room. And this is my consultation room. It's a fairly big place. It's a bit messy, and this is during MCO. And the other room is my second consultation room. This is where, if I have a fellow, they sit here, or another doctor maybe works with me will sit here. And I have a nurses room and audiovisual room. This is where the nurses do their work, and also maybe teach patients, counsel them, and also show my videos, the operating videos here in this room. And of course, I've got this treatment room, which is the biggest room in my office. This is my ultrasound. There's a couch with an ultrasound. And on the other side of it is the office hysteroscopy setup. It's got a whole tower here, a chair, and all the instruments here to perform the office hysteroscope. So I see my patients and do office hysteroscope in and out, and so it is very convenient to do this office hysteroscopy. So in Malaysia, outpatient consultation fees in private clinics are not covered by private insurance. This is important to understand. The patients have to pay out of their pocket for outpatient treatment, including office hysteroscopy. And if the patient wants to pay by insurance, then they have to be admitted into the hospital, and we have to do a hysteroscopy in the operating theatre, and this is usually done under anesthesia. So for convenience, if a patient can pay out of the pocket at a low cost, they get done in the clinic. Now, this next question is, what instruments do I use for office hysteroscopy? Now, these are the instruments that I use. I bought this about 8 and almost 10 years ago, and I still use them. Light cable, electrocautery cables. This is the Betoki 2.9 millimeter telescopes. I have 2 of them, and this is the Betoki sheath. And I also have got diathermy needles, and these are the graspers and scissors that I use. Some years later, I bought this sheath, which is actually a slightly bigger sheath. The normal sheath is about 5 millimeter. This is a 7 millimeter sheath. This is useful, especially when you're trying to bring out big polyps, and also if the cervical os is patulous, this is quite useful. I will describe this later. And the water system I use is a very simple water system, just a bag with saline and a drip set that goes into this, and most of the surgeries are done just by this, and this is pumped we pump it up to about 70 or 80 millimeter mercury, and we do the procedure. It's a very simple setup. I also have bought this Gubini resectoscope, which about 4 years ago. I rarely use it in the clinic, and this sometimes I take it to operating theatre to do it when it's under GA. But this is a 5 millimeter resectoscope that can be used for in certain cases, but I rarely use them. So next is preparation for office hysteroscopes. How do I prepare? As you all know, I am a fertility specialist. I see a lot of patients for IVF and also for IUI and infertility consult. I tell all my patients when they come for the first visit to see me on the 8th to 10th day of the menstrual cycle. Now, I do this because I can do all my investigations in this visit. So when the patient call up that they want to see me as a first visit, so they will come and see me on the 8th to 10th day of their menstrual cycle. And also tell them that they should abstain from sex for 3 days. And when they see me, first I'll take a history and I'll perform an ultrasound to look for abnormalities in the pelvis. And also at the same time, on the 10th day, I can look at the follicles to see whether they are ovulating. So that's one part of the procedure that is done. Then I'll of course send them. They come usually early in the morning. I usually see them, and as one of the first few cases in the morning, 9 o'clock in the morning, the husband would have gone to do the semen analysis, and then the lady will then be sent to. If I didn't find anything wrong, she will be sent to do a hysterosalpingography. And once the hysterosalpingography is done, the patient comes back to the clinic. I'll look at the hysterosalpingography, and based on that, I will do an office hysteroscopy there and then. No appointments on the same day. So when the HSG has been successful, I usually do the transvaginal, I'll do the office hysteroscopy without misoprostol. But in some patients, if the HSG has not been successful or they come on another day, then I will use misoprostol, which is cytotec. So if no HSG is done and the patient is very anxious, then I'll place a tablet of misoprostol, and I usually put it only 30 minutes before the surgery. And many people put it many hours before. I find 30 minutes is sufficient. The reason is because I don't want the cervix to be too dilated, and that will cause leakage, and that causes the whole problem. So just about 30 to 45 minutes, at maximum 1 hour before the procedure is sufficient in most patients. And if during the procedure the patient is in pain and I have not put in a misoprostol, I'll stop the procedure, I'll put in a misoprostol, and then I'll go back 30 minutes later and do the procedure if that can be done. Of course, if it cannot be done, then I'll cancel it and probably do it under general anesthesia. Now, the disadvantage of routine vaginal misoprostol is that the patient's cervical os becomes too patulous and leakage will be done, and the cavity cannot be seen very clearly. So this is the reason why I don't put it I don't put it routinely, and also don't put it often. Only in selected patients I use vaginal cytotec. Now, if that happens, say I'm unlucky and I have leakage, then I will use the bigger sleeve, and that is the purpose of the bigger sleeve, the 7 millimeter sleeve. Now, rarely I need to dilate the cervix before performing office hysteroscopy, and I use these plastic dilators, but this is rarely done most of the time it can be done without any dilatation. So the next is, in this way, I get all the investigations done in one visit. These are the tests that I do in that one visit. I have this basal ovulatory monitoring. I know I've got a rough idea whether the patient is ovulating. I have the semen analysis done. I have a hysterosalpingography done to know whether the tubes are blocked, and I also do the office hysteroscopy on the same sitting. And all these are done while I'm seeing patients in the clinic. So if I see, say, 20, 30, 40 patients, in between I'll be doing probably 8, 9 office hysteroscopy in the same day. Now, how do I perform the office hysteroscopy? Now, this is a short video that I took several years ago just to give you an idea of my office setup and how the procedure is done. Now, while I'm seeing patients, my nurses will be preparing all these instruments, and this is how my clinic is on the other side. On this side is the ultrasound machine, and this is the other side. This is the tower that I have. It has got the basic setup of you can actually do laparoscopy with this, but for performing the office hysteroscopy, this is a chair, and this is how my nurse is preparing the instruments, and she will be preparing all this, setting it up, and I'll be consulting patients. I'll be seeing patients in my other room, which is just adjacent to this room, while this is being done. And when it's ready, then I'll perform the office hysteroscopy. Now, she is of course soaked all these instruments and get all these instruments ready. And once the instruments are ready, she will prepare by sleeving the telescope. And here this is the light cable. And then what she will do is she will then get this drip sets ready, and then assemble the instrument, which is one sleeve into the other. And then this is the Betoki 2.9 millimeter telescope. I never got around getting the 2 millimeter telescope. I could manage with this. And then she will then clean the telescope and then attach a sleeve to it. In this way, we protect the instrument as well as keep everything sterile. And so this is attached, and then this is then used to sleeve the camera system. I think most of you will be doing the same thing, but this is the way that I do. And also the drip set will be set up, and my other nerve will then attach the camera. The camera is not soaked, so it will be attached to this system, and I'm ready. So once I finish, once they say the patient is ready, and the water is then placed, and I'm ready to do the scope. Light source is attached, and so I'm ready. So I'm just going in, and this is an office hysteroscopy in real time. This patient had a small polyp, so we're going in, and I use a non-touch technique, vaginoscopy technique, described by Betoki. And you are in. This patient had a hysterosalpingogram, so there's a little bit of bleeding, and so I'll go in and then get into the uterine cavity. And the principles are the same. You have the cervical ostium at the bottom so that you can get into the cavity easily. Once it's in, there's some bleeding, you can open the tap to release the blood from the endometrial cavity. So we can look at I'm going into the internal os and into the endometrial cavity. Once I'm in the endometrial cavity, I'll look at the ostium, both the ostium. And so here, this patient, this is the left tubal ostium, and then turn the scope around to look at the right tubal ostium. And then when I come out, this patient has a small polyp. So at the same setting, we'll remove this polyp. So this is an old video. This video is about probably 4 years old. And so at that time, we use a scissors to remove this polyp. Now the technique is slightly different, which I'll describe a little later. So now here you can see the patient is actually watching what I'm doing, and this is the polyp. This is my screen, and the patient has got another screen to see the procedure. And the polyp is then detached, and you can see that I'm doing that using I think this is a 3 French instrument. So the polyp is cut, and then once the whole polyp is detached, then I will change to my nurse will bring in the other instrument, which is a grasper, and we will remove the polyp at the same sitting. So it will take me less than 5 minutes to do this procedure, and once the procedure is done, I am back in my clinic seeing patients while the nurse will prepare the instruments for the next patient. So here I'm putting in the grasper and then holding on to that polyp, and then the polyp comes out, and the procedure is done. So I just unglove, and then I go on to carry on with my clinic procedure. So this is how the procedure is done. So what I do post-procedure, after the procedure, most of my patients only suffer slight pain during the procedure. I didn't mention that before the procedure, I usually give them a tablet of analgesic. Usually mefenamic acid is sufficient about 30 minutes before the procedure. And the findings are then discussed with the patient and the husband. They are then planned for future treatment, whether we are going to give them just fertility pills or we're going to move on to IUI or IVF, depending on what the findings are. And some patients will have some pain. If they have pain, then I'll rest them in a room in the next in my second consultation room. There's another couch there, and they will be rested there. And very rarely they will require a second analgesic. So what are the types of procedures I perform in this clinic? And so there are many different procedures we do. First of all, of course, in infertility patients, I do a routine office hysteroscopy for all my patients. to look for any abnormality. And also I am a believer of endometrial scratching. Now most people do endometrial scratching when there is 2 or more uterine what they call as implantation failure, but I believe that it is got its benefits, so I do routinely for all my patients. So let me show you what I do. So this is a 1.5 minutes video showing exactly what happens during an infertility workup. So the patient comes in, and I go in this patient, I place in a cytotec tablet, which was just half an hour is sufficient, and I go in non-touch technique into the cervical os. You can see the cervical os is small, and you go into the external os, and then you go into the internal os, and you're in the cavity. And once you're in the cavity, you just look around. This is the ostium, this is the left ostium, this is the right ostium, and looking around, the cavity looks perfectly normal. Then I place in a scissors, and I'll just make a small scratch. My scratching means just a light cut on the fundus of the uterus, and then the surgery is over. The instrument comes out, and the hysteroscope comes out, and I've finished the procedure. So this is 1.4 minutes. This is about 1 minute 20 seconds, and the whole procedure is over, and I'm back in my clinic to run my clinic. Okay, so other types of procedures that I can perform is, for example, if the patient's hysterosalpingogram stated that there is a proximal block, then I will cannulate at the same time during the hysteroscopy. This is such a case. So this patient has got a proximal tubal block on the left side. So what I will do is I will go in, as I showed in the earlier video. So you go in with the hysteroscope. Once you pass, this one is a little bit more difficult. Than this patient has a hysterosalpingogram, but it was slightly more difficult. If it is slightly more difficult and I can see the external os by just rotating the office hysteroscope, I could gently pass through the internal os. This always happens. But when you come into this kind of situation, you're worried that you may perforate. Then you may want to probably place a grasper inside to know where you are. And if you can see, then gently, by gentle rocking the office hysteroscope, you can get into the cavity. I think this patient, I was able to enter without placing in a grasper. So this is the procedure that I do. And as long as the water flows and I can see the ostium, I'm happy to move forward. If I am not happy, then like in this case where it looks like I'm not sure whether I'm in the right direction, then I will put in a grasper and then look for the correct position of the internal os. And here I'm waiting for the grasper. The grasper will come in, and I will then go into this area to make sure that I'm not in a false passage. So waiting for the grasper, and the grasper has come in, and all these are real time. I didn't edit this video, hysteroscopy, so I know that I'm in the right place. I can take out, as you know, this 5 millimeter telescope. Once you put in the grasper, the water will not flow, and you have to take out the grasper for the water to flow through. And then what you do is you just move gently into this area, into this defect slowly, and into the internal os, and then you are in the uterine cavity. Of course, this one took a little longer than the earlier case. The earlier case you went into very easily. So now I'm in the cavity. Now I look around to see whether there are any pathology. This particular patient, there's no pathology. Both the ostium looked okay, and I know that this particular ostium, that is the left ostium, is blocked. So can I do something to open it up? So in the same setting, what I do is I'll open it up just by using a ureteric catheter and a guide wire. So it is technically a little bit difficult. When I first started this procedure, it was difficult. This is a ureteric catheter, the same catheter that the urologists use to stent the ureters. And I will try my best to get into the ostium. It's sometimes difficult. Like in this case, it was difficult. It's difficult to rotate the catheter to place it over the tubal ostium. So as you can see, my guide wire is going all over the place. If you have that nice designed catheters that can turn, it will be better. But I have managed to do all my tubal cannulation using just this ureteric catheter. It's cheap, It's easy to do, and it can be done in one setting. Now I've already placed it right on top of the tubal ostium, and then the guide wire is going in. So what I do is I ask my nurse to push the the guide wire into the tubal ostium as much as she can, and watch the patient's face whether she's in pain. If she's in pain, I'll stop. Usually the guide wire goes in very well. As you can see, there's so much has gone in, and I make an assumption that this tube is opened up. So this is a service that we provide for all our patients with proximal tubal block at an office setting. So recently I had this this patient whom I had to do a intrauterine, I had to do a HSG in the operating theatre. This patient had vaginismus, so I had to do a HSG under general anesthesia, and she also had a right proximal tubal block. And so the tube was cannulated just like what you saw in the video just now. And after the cannulation, I did the HSG again, and the tube was patent. And this is how it looked. As you can see, this is the first HSG before the cannulation, and this tube was blocked. And after I cannulated, it was patent. So what I've been doing all this while has been probably fruitful. I will never know, because I've never followed up this patient to see how many of them got pregnant. And I've probably done about 2,000 office hysteroscopies with about probably 200 cannulations, and I have not followed them up to see how many have actually got pregnant. So what are the other procedures? Polypectomy is a very common procedure that I do in the office. I think all of you all do as well. Polyps can be of different sizes. I showed a polyp that I was removed just now, and this particular case, this we did a few days ago, was a polyp, and so it was also removed in the office setup. So here I'm again going in into the uterine cavity. So I'm in the uterine cavity, and you can see that there is a polyp, a small polyp on the lateral wall. So the current thinking is not to use scissors, but to use a grasper to try and pull the polyp out of its roots. So here is what I'm doing. I'm holding, using a grasper, and then pulling it, pushing it, and then releasing the polyp from the wall. Other topics are large polyps. Now, large polyps are slightly difficult to do. This is a large polyp. This is quite difficult to do in the office setup. I don't have many instruments like all these amazing instruments, the shavers that we discussed. So I just have a scissors. So with the scissors, I have to probably cut it. I couldn't cut it longitudinally, which is the preferred method. Make them into what we call as French fries, and then remove it. But because it is transverse, I have to cut the polyps transversely, and then after cutting it transversely, this can take some time to remove, to be removed from the cervix. So here the larger diameter of the hysteroscope is more useful. So here it's all cut, and then I have to then slowly take it out. It takes longer time. This after the polyp has been removed. As you can see, it collapses. The endometrium collapses because the cervix becomes patulous. So I'll move on to the next video. Missing IUCD is another one we do very often. This is an old video where a patient was having a Lippis loop, and this one was done about maybe 8 years ago. We don't see this Lippis loop now. So this patient had this Lippis loop stuck into the endometrial cavity, and she didn't want to have it done under general anesthesia. So under sedation, under office hysteroscopy, I managed to pull it out. So this is the Lippis loop, and so the grasper is then held, and then the Lippis loop is then removed. It is more difficult to do it, especially if the IUCD is quite adherent to the endometrial cavity, and this was one of them. It's quite difficult to remove this Lippis loop. Okay, I'll move on to the next video. Now, uterine adhesions. Now, as a fertility specialist, I'm always looking for pathology in the uterine cavity, because if I'm going to do IVF, I want the endometrial cavity to be perfect for my embryo implantation. So we try to look for any lesions. So these uterine adhesions can be a problem, but they may be very minor and still affect implantation. Here you can see the endometrial cavity looking quite normal, except for this small adhesion over the right tubal ostium. So when you see this kind of lesions, it's better to remove the lesion during this office hysteroscopy. And this is the benefit of doing routine hysteroscopies for all infertility patients especially in an office setup. So this particular polyp was then just removed with a grasper. Okay, I'll move on to the next case. Now, cutting uterine septum is not my I don't like to do this in an office setup, but some patients are not very rich. They cannot afford to go to operating theatre. So in such situations, I will do as much as possible of this incision of this uterine septum. Current thinking is actually excision, but in the advantage of doing this is I could do as much as I can, and I can bring the patient back in a month's time and then repeat the procedure. So that's a big advantage as opposed to patient going under general anesthesia. So this is quite a large septum, and there's a lot of tissues. So I did it because the patient asked me to do it under an office setup. So I did it up to the level that I'm comfortable. When there is bleeding, when there's a slight bleeding seen at the end, I will stop. I've stopped, and I brought the patient back and relook at the septum to see whether it is sufficient for the patient to conceive. So this is another procedure that we can do in an office setup. So I'll move on. My time is up, almost up. Now this is an interesting case. A 27-year-old lady, Virgo intacta. She had hypogonadotrophic hypogonadism. She never had a period for the last 27 years. She had an identical twin sister with the same problem, monozygotic twins. And so I did a transrectal ultrasound, and you can see the uterus was so small. It's a very small uterus. This was last year. And I persuaded her to do an office hysteroscope. So we did the office hysteroscope without trying to disturb the hymen. And this is the case. So this is one of the things that we can do. We can do office hysteroscopy or even vaginoscopy. Say there's missing sometime foreign body in the vagina in a young girl. This we can do a vaginoscopy and a hysteroscopy. For this patient, I did an office hysteroscopy. So we managed to try to gently go in without breaking the hymen, and got into the vagina. And this is the small cervix. And so gently I was able to enter. This patient didn't have any vaginal cytotac, and so with gentle pressure I was able to get into the cavity. And so the cavity, as you'll see, is very small and very pale. So with gentle pressure and with the flow of fluid, the cavity was gently entered. And so I was in the cavity, and I could see the cavity very well. This is the ostium, and you can see it's very pale. This is another ostium. And so I was happy that she has a normal uterine cavity. So so that was good. So what I did subsequently is to give her hormone replacement treatment. She had hormone replacement treatment for 1 year, and recently she got married. And I saw her a few weeks ago, and her uterus is now large and nice, and now we are looking at ways in which to help her to get pregnant. So of course she will need some kind of FSH injection to do ovulation induction, and then maybe even IUI, she may be able to get pregnant. We also see a lot of uterine abnormalities. As you know, this is a 3D ultrasound showing uterus with two uterine cavity and also a uterine septum. And this is a large uterine, this is a lady with biconvate uterus. Not only biconvate, it's a double uterus, double cervix, and double vagina. So this is the right cervix, and you can see that this is the right side. I've gone into the right septum to look at the uterine cavity. This girl is only 25 years old. She also got polycystic ovaries, and her husband's sperm count is also low. So we were thinking of doing IVF, and we just started the IVF program recently. So this is the one cono of the uterine cavity. It looked fairly normal, and then I had to come out and then go into the other side of the septum, complete vaginal septum, to go to the other side of the septum to look at the other cervix. And this is I'm out, and then I go into the other side of the septum. This is the whole septum actually, and this is the other side. I go into the other side and go into the other uterine cavity, and this is the other uterine cavity. So once it's in, and so this cavity is also normal. So now we are planning to do IVF. The difficulty is to decide how many embryos to transfer, and I have had one experience of doing this about 18 years ago, where I placed one embryo in each cavity and the patient had twins. This is the last video I would like to show. This is a lady with who had Manchester repair. Her cervix is completely gone and she wanted to get pregnant. So this is a video that I created, so I'll show you all the video. Let me fast forward. So it's a 40-year-old lady, one child, 14 years of age. She underwent a Manchester repair for prolapse of the uterus in 2017, and she saw me to discuss the possibility of conceiving again. So I noticed that her cervix was almost absent and there was a small pinhole cervical canal. This is how the uterus looked. This is a uterus, there's no cervix at all. I sent her for a hysterosalpingogram, and the radiologist could not cannulate the cervical canal to do the hysterosalpingogram. So I decided to do an office hysteroscopy, and this is the office hysteroscopy. So as you can see, the cervical os is almost non-visible. It's a very thin pinhole. This video is running at 4 times the speed because it took some time to do this, and this patient refused to do it under GA. She wanted to do it in office setting, so I said, okay, I'll try. This is best if this is done under ultrasound guidance, but my clinic is set up in such a way that it's very difficult to bring in the ultrasound to do. So I thought I'll just try to just use a grasper and then go in with the telescope to go into the cavity. So using a grasper, I just slowly dilated the cervical os, and the only analgesic this patient had is mefenamic acid. And then by rotation, slowly I try to follow the cavity. If I feel that I'm not in the right place, then I will use a grasper to feel my way. And by this rotational method, slow rotational method, and with the saline flowing gently, I managed to enter into the cavity. As you can see, as you go in, you have to draw out, go in and you draw out to see where you are, so that you are in the right direction, so that you will be able to get into the cavity. So with this technique of using the hysteroscope as the dilator, slowly I managed to get into the cavity, and this is both the ostium. Both the ostium looked good. So this is an interesting case. Of course, this can be done under GA, but you can do such cases even in an office setup. So advantages of office hysteroscopy, you all know, is fast, quick diagnosis, no waiting time, no anesthesia, low cost to patient. As you can see, I've done most of my office hysteroscopy, almost 95% of the time it can be done in the office setup. And the disadvantage is, of course, in my country, it's not covered by insurance. One famous Belgian hysteroscopist says that he will do an office hysteroscopy, and if he sees a polyp, he will stop, and then he will take the patient to general anesthesia to do the polyp, because the insurance doesn't cover removal of polyp in the clinic setup. We are not the same, so we just do what we can in the clinic. So it's all boiled down to how the insurance companies are paying for what you can do in this setup. Some patients will have pain, and it is difficult to do in very anxious patients. I always talk to the patient. I said, you will have a little bit of discomfort, pain. If there's pain, I'll stop. Is it okay? If they say it's okay, then we'll proceed and do the office hysteroscopy. I have one patient who had a vasovagal attack. That means she just stopped breathing while I'm doing. So I'm always very careful in older ladies and patients with medical problems. So I will not do them. Most of my patients are younger patients who are trying to get pregnant, and those are the patients that I can successfully do office hysteroscopy. So in conclusion, office hysteroscopy is a very useful tool for the gynecologists. Setting up can be costly. The equipment can be costly. Now I know Stotz has got this kind of boxes that we can buy, but you still have to spend quite a bit of money to set it up in an office setup. And many procedures can be done in the clinic. You'll be surprised at the type of cases that I can successfully do in my clinic. And that's it. Thank you. I know I overshot by 4 minutes. Thank you. Are there any questions?